Hello, everyone, and welcome to the Natus Neurotraining Academy webinar presentation. I'm Dr. George Grudzik, Senior Global Medical Education Manager for Brain and Neural Pathways, and again, it's a pleasure having you join us. Our webinar is entitled Natus Elite Software Product Tour Number 2, Getting the Most Out of Your Nerve Conduction Studies, as presented by Dr. Sanjeev Nandedkar. With over 30 years of experience, Sanjeev is an award-winning author, editor, and reviewer, researcher, instrument design engineer, teacher, and clinical expert in the EMG field. He has delivered lectures, workshops, and seminars in over 25 countries at universities, hospitals, and EMG conferences. As an editor, Sanjeev started the EMG on DVD educational program series. Also, in collaboration with other renowned clinicians, he developed the Motor Unit Number Index, the MUNIX, along with multimotor unit analysis, the MMA, and turns and amplitude, the TA methods available on Natus EMG systems. His primary research interest is in automatic analysis of EMG signals, modeling EMG signals, and technical aspects of EMG waveforms. Sanjeev is a colleague and currently senior consultant here at Natus Medical.
Good morning. Thank you, George. So welcome back to the Natus Elite Tour. This is part 2 as indicated by George. So before we start our tour, let's just look at what happened in the last tour. Our focus was mainly on the nerve conductions and needle EMG. And some of the things that we highlighted was the ability to compare different nerves. For example, I can compare the responses from a median nerve with an ulnar nerve. This is something that you may want to do, not necessarily this combination, but in neuropathies, you want to look at distal conduction, rather the lower limb versus upper limb nerves. Or if you are looking at mononeuropathy multiplex, you want to look at different nerves. This is what we call NCS Insight, and you can see this window on the right that allows you to make such comparisons. Here is a comparison of motor with F waves, so this can be useful to look at conduction in distal versus proximal segments, Guillain-Barré syndrome perhaps. Or we can make a comparison of motor with sensory nerve conduction to assess the severity of carpal tunnel syndrome, to localize the lesion, whether it is distal to the plexus or proximal to the plexus. We can also make a comparison with the previous study. So in the top, you can see the current investigation. In the bottom window, you can see the previous investigation. And this can be useful for research as well as assessing the disease progression. Notice on the right-hand side, you can have an entire history of all the testing that is done on that patient. We always use auto compare to look at unilateral lesions. So you can see the left side on the top, right side on the bottom. Similarly, the traces accordingly on the left-hand side. But now we can also look at the side-to-side difference, the absolute values of latency difference or velocity difference and so forth. And we can also have reference values to assess the significance of side-to-side difference. And let's not forget about how we can set up these reference values for the common parameters based upon age, height, gender, etc. We can also have factors like temperature correction factor, age factor. We can have logarithmic transformations, z-scores, and so forth. We looked at the 2-channel conduction studies. So here is an example of doing the ADM and FDI recording simultaneously in an ulnar nerve conduction study. So you have got separate tables and separate waveforms. Essentially, it gives you a better view of nerve conductions in using 2 different muscles at the same time. You don't have to stimulate the patient twice. You are reducing the patient discomfort. And you can also do this for the fibular or peroneal nerve. Notice there is no recording for the ankle stimulation when the recording electrodes are over the tibialis anterior muscle. And then we also looked at the combined sensory nerve conduction studies. You can be on a single screen within a single test, but do motor and sensory. And that's the kind of an interesting way, at least to me, to do some of our routine conduction studies. So you always have the motors and sensories on the same screen. We looked at the complex stimulation protocols. This would be more useful for research studies. So you can define stimulation for each site. So here is a magnetic stim, in which case we can have the appropriate stimulator. Even within the routine protocols, we can use different types of stimulations, simplifying our workflow. That's the key message over here. We looked at the reference setup package, which now provides far more images and other things. Plus, we also get a subscription on the training material to review videos and other things. And so that becomes a laboratory subscription, can be used for 1 year by all the trainees and fellows, which makes it very useful. We looked at the late responses, the addition of the response table, which can also go into the report. We can also place the results of F measurements into the motor report. This can be useful, for example, doing the central conduction time and other kind of studies. We looked at the EMG report, and here is a nice feature where we can rearrange the order of muscles in our table using this left-right arrow key. So in this case, I have rearranged everything based upon a nerve. Maybe you want to indicate that there is a selective abnormality related to a nerve. Or you can reorganize it by roots, and you may want to show that there is abnormalities based upon the myotomal pattern in a group, so forth. We also looked at the report, a lot of changes to the report. We can highlight our test nerve. We can have some extra space between separate nerves. We can group them by the side. We can group them by the nerve itself. We can group them by time. We can center the measurements. Lots and lots of changes that have been made to the report, because that's actually the product of the laboratory, and that should be a really nice looking document. And of course, you can do the online reporting or offline reporting. So that was a quick review of what we went over during the part 1 of the tour. And today, we are going to discuss something that is less common. So in the tour 1, we were thinking mainly about neuropathies, primary muscle diseases, routine needle EMG, and so forth. Today, we are going to focus on 3 aspects. One is the neuromuscular junction testing. And then we will also touch up briefly with autonomic testing, as well as evoke potentials. We have a very exciting test. So what I'm going to do is give you a quick background on the material, because that is related to the workflow on how the test is performed within the Elite software. And then actually I will do a live demonstration. Hopefully we will have good quality signals. I'm doing this from my home. So let's see how things go. Again, our theme is making it easier in the clinic. So repetitive nerve stimulation, quick background. This is used to investigate the efficacy of neuromuscular transmission. It is when neuromuscular junction disease is suspected. For example, myasthenia gravis, Lambert-Eaton syndrome, botulism, and there are other conditions as well. When this study is normal and we still suspect that the patient may have a primary neuromuscular junction disease, that's when we will do single fiber EMG. This is the most sensitive test. Again, keep in mind that repetitive nerve stimulation itself is non-specific. It can be abnormal in other conditions, such as neuropathy, motor neuron diseases. This is well recognized. And now we have some variants of repetitive nerve stimulation concepts that are available to look at channelopathies or periodic paralysis and other things. But I like to group all of this together as part of repetitive nerve stimulation. So our methodology, there are many different ways we can do this. There is a low frequency repetitive nerve stimulation. That's what we typically think about when we talk about RNS. We can also do high frequency stimulation when the patient cannot cooperate. For example, in infants, we may want to get the facilitation investigated by electrical stimulation, so high frequency repetitive nerve stimulation. There are some laboratories that also do what is called long duration stimulation. So you stimulate the nerve for a long time and then look at how the amplitude changes. And I think this is probably what led to what are known as the short exercise and long exercise tests. So these are the different variations of repetitive nerve stimulation. There are also other protocols, for example, cramp fasciculation, where you can deliver a train of stimulation to see if a cramp is developed, but I will not go into that. So in our main menu, this is where we can find the repetitive nerve stimulation tests, the low frequency, the high frequency, and the long duration. I will not discuss the long duration. Let's start with our repetitive nerve stimulation in a clinical setting. This is typically the low frequency and the high frequency. And here is a wonderful protocol that is described in IFCN guidelines. It was authored by Professor Stolberg, and I like this diagram very much. This is what we are trying to do in the EMG laboratory. So the protocol within the software is actually based upon this diagram. So there are two situations. We are thinking about a postsynaptic abnormality like myasthenia, where we do a baseline study. We expect a normal amplitude CMAP, and we may see decrement. Then the decrement is typically maximum at 4th. We exercise the patient for 60 seconds, as indicated over here, and then we record after exercise to look at exhaustion. If you have presynaptic abnormalities, you typically have a low amplitude CMAP, as shown over here. That's your clue that this may be a presynaptic abnormality. You get a decrement. Interesting thing, the decrement actually can continue to 6th or 7th. In myasthenia, you kind of get a recovery, more of a saddle shape. But as indicated in this diagram by Professor Stolberg, you can see the amplitude can continue to go down a little bit, even at 6th or 7th. And this is now followed by only a 10-second exercise over here. This is mainly used to look at facilitation. You can also look at facilitation in myasthenia if you wanted by using a 10-second exercise. It's important to recognize that exercise is done for two reasons. One is to look for facilitation. If you are interested in facilitation, then 10-second exercise is more than enough. If you are looking at exhaustion, now you need a 60 to 70-second exercise. So in terms of defining protocol, there is no fixed time for the exercise that will be used. Let's keep that in mind. And then also we get exhaustion at 1 to 3 minutes. So within the software, we have two different tables that you can see. The first one is for automation and exercise timers. So this is something new. You can define how long you want to exercise, and then when do you stimulate, and so forth. And then we have another table which is seen on the left, where you can define the stimulation frequency, the train length, the pause period, automatic acquisition. So by using these two tables, you can streamline the operation of repetitive nerve stimulation study. You can focus more on the patient rather than pushing buttons on the instrument. Here is a high frequency stimulation. Again, you can see the baseline at the top. This is high frequency stimulation. And so some of the things that are different in this program compared to the low frequency stimulation is the calculations. Obviously, we want to look at the decrement at the 4th stimulation. But when you do high frequency stimulation, you want to look at facilitation. So you can look at the initial amplitude over here, the final amplitude over here, and then look at how much the amplitude increased. So here you can see the amplitude went up by 26% or so. So this can be real facilitation, it could be pseudo facilitation, and other things. Just wanted to emphasize slightly different measurements within the programs. And we also have the ability to show all our measurements tabulated in the data if somebody is interested in research. And this table can also be transferred to the report now. Previously, we had only the summary table going into the report. This is a new feature in Elite software to also introduce this individual measurements. And graphical presentations are always useful to look at our day summary data. So here you can see the high frequency stimulation amplitude. This is baseline high frequency stimulation. And then you can look at exhaustion and other things after 1 minute. When it comes to research setting, well, we can use different protocols, and you will find them in the research folder. Specifically, there are two tests. There is something called short exercise test and a long exercise test. So in a short exercise test, you always begin by recording the baseline compound muscle action potential. And we are going to stimulate the nerve 6 times at 0.1 hertz. That means you are going to stimulate once every 10 seconds. So it takes about 1 minute to complete the train of stimuli. You have the patient exercise, and then you repeat these trains as necessary. Usually this is done about 3 times to extract different patterns. And we are looking at amplitude changes within these individual trains after exercise. Professor Fournier has described a lot of patterns, particularly when the abnormality is a channelopathy, for example, in patients with myotonia. So that's a short exercise test. And in a long exercise test, you record the baseline Cmax, and then you have the patient exercise for 5 minutes. It sounds very torturous. It's very, very difficult. I mean, you think about 30-second exercise being long. This is 5 minutes. Obviously, you kind of give them a little bit of break for 5 seconds after every minute or so. Anyway, after 5 minutes of exercise, you record Cmax once every minute, probably for the first 10 minutes. Later, you can do it every 2 minutes or so. But this takes a lot of time, just almost about 1 hour. So it's time consuming. So it requires more detail, more attention, making sure that you are stimulating at the right time. This is useful to investigate, again, channelopathies or periodic paralysis. Here is a short exercise test. It looks exactly like repetitive nerve stimulation done at low frequency, but this is super low frequency. Typically, we do 2 to 3 hertz repetitive nerve stimulation. In this case, we are doing it at 0.1 hertz. The nice thing is that we can see each and every amplitude and area measurement, and we can look at the pattern. Similarly, when we go into the long exercise, this is the way you can set up your table. This is baseline. You are going to give only one stimulus. So the train length is 1, and then you wait for 1 minute initially, and then you can stimulate after 2 minutes. And you can also give an warning before stimulation. So this reduces a lot of stress in long exercise test. Okay, so now it's going to be the time for demonstration. So let me switch over to our software over here. I will start with repetitive nerve stimulation. So this is going to be the basic low frequency stimulation. Give me a few seconds while I place the electrodes. So we need standard placement of electrode, just like we are doing a motor nerve conduction study. This is where I like to place the stimulator on the patient and make sure it doesn't move, because this test usually is going to take about 5 minutes or so. I don't like to use the probe, especially if I'm going to do the distal limb studies. Sometimes putting the probe and can be challenging, holding it in place. Anyway, so here we are in the baseline mode over here. I will increase the stimulus intensity. We are trying to get the Cmax. and you really want to make sure that you are at supramaximal intensity. So this is supramaximal. I never use recurrent stimulation in the stim setup mode because that defeats the purpose of repetitive nerve stimulation test. So here is our amplitude. This is normal. If it was a presynaptic abnormality, you would recognize a low amplitude right when you are setting up your CMAP. Let's go to the repetitive mode. So this is going to be 2 Hertz. You can set up 2 Hertz, 3 Hertz, whatever you like. This is going to be my baseline study. Now, I like to do a baseline of 10. Many times people like to use a shorter train. 2 important reasons. As I indicated earlier in the protocol for Lambert-Eaton syndrome or presynaptic abnormality, sometimes your decrement continues beyond the 4th stimulation. So I want to see that. And in presynaptic abnormalities, you get more of a recovery. So that's a physiologic reason why I like to have a train of 10. Secondly, if there was some artifact and the electrodes was coming loose, you may also get a decrease in amplitude. And that will continue with all stimulations. It will not show any recovery. So to rule out the technical as well as get better understanding of underlying physiology, I like to use a train of 10 stimulation, at least for the baseline. Afterwards, you may resort to lower stimulation train. And this is something that you can set up in your train label. So you can have the baseline at 10, and then later you can switch to 4 stimulations if necessary. So now we are going to do a 10-second exercise over here. So here is a new feature. I'm going to turn on the exercise timer. Let me select the next trial. So this is a window that is going to give us feedback about time. You can choose the amount of time, 10 seconds, 30 seconds, 1 minute, etc. We are going to acquire automatically. So this window can be on a separate screen. So here we go. So contract. You can hear the EMG activity. You can also see it in the EMG monitor trace. And okay, relax. Let the patient relax. Here is a warning. And we will have the stimulation delivered automatically. Here are the calculations, our decrement. We also have the facilitation, which is comparison of the first amplitude in each train with respect to baseline. Sometimes the markers are not correct. If you change the marker on the first trace, it will also adjust the marker on the other traces. This I find particularly useful when doing facial nerve stimulation. You can change the spacing between them like this. You can choose, you can look at all the amplitudes. If you wanted to use number 5 for decrement, you can choose that. And you can restore it. You can also use number 2 as a reference. Here is a clock, which is telling us the time since stimulation. Here is a clock that is time for the next stimulation. So at 5, that was a warning. And here we have next. You can see I'm talking, I'm conducting this webinar and doing the study at the same time. And it's all possible because of automation. I don't have to pay attention to clocks or stimulus intensities or other things. Once it is set, it's in kind of an autopilot. You can also put comments if necessary over here from the drop-down list, normal, abnormal, etc. So this was our 10-second protocol. If you wanted to do a longer exercise, let's say I want to do a 1 minute, the routine will be the same. Now I choose the post 1 minute exercise. I will turn on the auto acquire exercise timer. And this time I'm going to say, this is going to be 1 minute exercise. So in this way, the repetitive nerve stimulation workflow can be streamlined within the Elite software. The process is going to be exactly the same, so I'm not going to repeat it. Good. Let's look at the high frequency stimulation. So we have a customized protocol over here. The workflow is exactly the same. So I will go to the supra-maximum stimulation over here. Come down. This is going to be the baseline stimulation. Notice this is done at 2 Hz frequency. Now I come to the next train. This is where I'm going to turn on automatic acquisition. Also note that my rate is set at 20 Hz over here. So this is all pre-programmed. You don't have to fumble through it. All you have to do is pay attention to the patient, stabilize the tested muscle, and stimulate. And you can very easily see the increase in the amplitude. How much do you want to stimulate? Well, we did a study on the firing rate of motor units and found that even at moderate force, the motor units fire under 15 Hz. So if you exercise them for 10 seconds, typically at moderate to high force, you are looking at 100 to 200 discharges. So you really don't need to stimulate for a very, very long time because the firing rates go very high only at maximal effort. So my preference is to use 20 Hz. I mean, that's at kind of more than moderate force level contraction, and 100 stimulations works quite enough. Here is the clock, which is counting down, and at 1 minute, it's going to give us stimulation. We have the decrement over here, but we can also see the amplitude change in the last. It is 51.8. Let's go through this train of stimulations. Note that it is back at 2 Hz. No accidental high frequency stimulation. You want to avoid it at all costs. Okay, so going back to our calculations over here, 51.8, that's the amplitude increase over here as a percentage. So within this train, you can see decrement, you can see facilitation, and all of those features. Of course, you have the comment column available. You can say normal, borderline, etc., etc. So to summarize, the Elite 2 software gives you a very nice workflow to manage this rather uncomfortable test. It is definitely uncomfortable if you are going to do high frequency stimulation. By automating, you can make things happen at the correct time with the correct frequency and so forth. Focus more on the patient. The same applies to the uncommon protocols that we use for the short exercise and long exercise. Okay, so enough about our basic test for neuromuscular transmission. Let's go into our advanced test of neuromuscular transmission. And as I indicated earlier, that is going to be the single fiber EMG examination over here. So in single fiber EMG, we use single fiber EMG again to investigate the efficacy of neuromuscular transmission. Let me start the slideshow. Seem to have lost my icon over here. That's okay. We can continue in this screen over here. So this is again useful to study myasthenia gravis, Lambert-Eaton syndrome, botulism. It is more sensitive than repetitive nerve stimulation, as I indicated. It is also non-specific. The issue with single fiber EMG, it is considered time consuming. It can take 25 to 30 minutes to study a muscle. Sometimes you have to do 2 muscles because the first one turned out to be normal, and it requires a lot of training. There are 2 modes of stimulation over here. There are 2 modes of recording. You can do it as a stimulated method, or you can do it as volitional. You can record using a single fiber needle, or you can record using a concentric needle. And now we have 2 different algorithms. These are the classic level-based algorithm and a peak-based algorithm. Each of those have specific filter settings and reference values. And as a result, in our program now, we have got 8 combinations based upon these three variables. So you choose the program that suits you the best. Here is a very important concept for single fiber EMGers. We have a new calculation which is called J-sum. So here is a triplet. I'm triggering on the first spike. This will give me jitter between spike number 1 and 2, 1 and 3, and that was 46 and 56 microseconds. The total of this is 102. This is called J-sum. Notice that if I were to use a different spike for triggering, or rather for measurement of interpotential interval, I can measure jitter between spike 2 and spike 1, spike 2 and spike 3. Again, jitter between 2 and 3 is 52. Jitter between 2 and 1, as we saw earlier, was 46. But this gave us a lower J-sum value, 98. And if I trigger on this spike, now it gives me a J-sum of even 108. This is not an issue if you have a single pair. It doesn't matter which one you use for measuring interpotential interval. But when you have a triplet or quadruplet, selection of the potential or the spike as a reference in jitter analysis can affect your measurements. So calculation of jitter is a very important calculation in our single fiber EMG studies, and that is something that is new in our system. There are many other changes. So rather than going through all of this PowerPoint kind of a thing, let's just look at some examples. So let's go directly to the demonstration part. Here we are. As I indicated to you earlier, we have got so many different programs. So this is jitter, volitional method using concentric needle. This is jitter analysis using multi-peak algorithm, volitional mode of recording with a concentric needle. You can see all of these combinations over here. What I'm going to do is, let's go to the multi-peak. This is the new algorithm. This is kind of blending the best of the EDX algorithm, and we also have the key point system. We have taken the best features from both systems and put them together. Let me choose the frontalis muscle over here. This is just basic noise, so I'm going to stop this recording. Let's erase this. Let's go to a pre-recorded signal over here, and this is a nice one. Now, before you start analyzing the screen, I wanted to look at this particular symbol over here, the red vertical arrow. Typically, in our EMG analysis, we have a crossbar. The vertical line indicates the delay, and the horizontal line indicates the amplitude level. We have now introduced what is called automatic level trigger. We are in the automatic mode, so you don't have to worry about the level. The level will be adjusted automatically, or it will use the peak and so forth. Let's just start with the normal way that we are accustomed to. So I will turn this thing off. One of the things I would like to emphasize that we are not getting rid of anything that we were used to. We are simply introducing new things, and we can decide whether we like it or not. So now I can actually set up the trigger level over here. Let's play the signal. So here is a triplet. Notice that we are identifying peaks over here. They are color coded. They are shown in a raster mode over here. You can see the interpotential intervals. You can see the jitter. And you can also see the J-sum value. So a lot of things are happening here. I will stop. So what happened when I said stop? I was triggering on the first spike over here. That should have appeared with great superimposition, but it doesn't. There are two reasons. One, we are no longer triggering on the amplitude level. And secondly, we are no longer using spike number 1 for jitter analysis. Let me expand this window over here. You can see the positions of the various peaks. This pink peak doesn't move. This is used as point of reference. So this is what we are using for measuring jitter. And the first peak is shown in the blue color, and the second one and the third one in the gold color. And you can see the arrows indicating which two peaks are currently shown for analysis of interpotential intervals and so forth. So we can see there is a single peak over here. Let me maximize this window. You can see there is a single peak over here because all these potentials are aligned over here. And you can see the jitter by variation in the peak position of the other traces. Our screen tells us a lot of measurements. So this is my active pair. Notice it has a blue highlight. That corresponds to the blue peak over here. That corresponds to the blue dots over here. And that corresponds to the blue squares over here. So there's a lot of color coordination involved in this because we may get 4 or 5 different spikes that are time locked, and it would be very confusing on which jitter analysis we are conducting. If I wanted to select this spike over here, I will simply click with the left mouse. Notice the change in the arrows, and we got things over here. So we have introduced new features, but we have also kept the old features available. If you wanted to get rid of the outliers, you can still use our traditional feature of adjusting IPI windows like this. Include or exclude traces. You can also adjust the right and left edges of this box. If there is interference that you want to get rid of, for example, you can see there are 2 waveforms over here, or 3 with high peaks. So there was some interference. I can use my rectangle tool to get rid of it. So everything is getting better. We have kept the previous good features and introduced some new ones. If there is something that you don't like, for example, I don't like peak number 1. See, that's the one that is selected. I can delete pair 1.1. Well, if it was a mistake, I can always click on reanalyze and bring it back. Maybe there is a peak that was present but not identified. So let me just change the gain over here. This is not a good peak, but for the sake of argument, let's say this is a peak that I would like to analyze. I can right click and say add peak. And using the Windows method, I'm going to put a horizontal bar so that the peaks can be detected. And notice I have introduced a green peak in my analysis. You can see the dots over here. So yes, there's a lot of automated analysis, but you have full control on manual analysis as well. If I don't want to keep this green peak, I will delete this pair. So that was a very nice way of doing analysis automatically. Let's analyze this signal again by using automatic trigger. So this was, so far it was manual. Now I have switched to automatic trigger. Let's play the signal. And this time you notice that there is not only a triplet, but there is another action potential or motor unit activity in the background that is being captured by our trigger. Fortunately, it was excluded by our analysis algorithm. You can see those traces in blue color over here. So anytime you have automated analysis, there is always the possibility of interference throwing off your analysis. So you always have full manual control. There's also some intelligence built into the system. Sometimes you may want to see the peaks better over here. They are too scrunched up. Let me change the time base to say 200 microseconds. That took the trace away. I can scroll this and bring them back. So this is a very nice way of looking at jitter at a very high speed and so forth. I can restore this. Let's look at our summary. Here is the review. We have a new table over here, which gives us a summary, exactly the way it has been recommended in various mini monographs and so forth. So there were 2 recordings, there was no blocking, there was 0% increase, no pairs with increased jitter, and all of them were normal. So let's imagine that you have a situation, you have recorded 18 pairs, the patient is getting tired and it's getting very difficult to get pairs. Nevertheless, you have observed some normal pairs or pairs with increased jitter and blocking. Why not add your own subjective assessment into analysis? So that's why we have this additional table over here. So let's say there was 1 pair with blocking, 1 with increased jitter, and 2 were normal. See, this updates your summary. Our number of recordings is 6, 4 that were done subjectively, 2 that were done quantitatively. So this is giving you a summary. The quantitative data, the median jitter, is based upon our subjective analysis, on our quantitative analysis only. If you wanted, you can also introduce the fiber density notepad. I'd rather make a separate program, but I will show it to you here anyway. You can say, okay, I found 5 singles, 2 doubles, 1 triple, and then you can keep adding this as you do the testing. But I had rather not do it in this window. I would set up a separate program. So that's indeed a very, very powerful feature for analysis of jitter, automatic trigger, manual trigger, peak-based jitter measurement. In our traditional analysis, we can also do level and peak-based analysis, entry of subjective findings, this new display of our interpotential intervals. So a lot of very, very nice features to make the test go faster. And hopefully, the software is also going to support you by getting rid of some of these spurious discharges that are coming into the system. If we were to do the stimulation method, then that really speeds things up. So let's look at some examples over here. This is multi-peak stimulation with concentric needle. I will choose a recording over here. So here we go. Here is my stimulus artifact. These are the potentials. You can see they are being detected. And here is their pattern of discharge. We are done. We have got about 8 different spikes that are identified over here. Here is the summary. Of course, we will need to go back and review all of these recordings and make sure that the analysis is done properly. So this is 1, and this is high jitter, and I can see there are some outliers. So I need to take that out. And what about this one? Well, that's the recording over here. Maybe there was initially a lot of jitter. I need to cut it down. You can notice that you can also do editing in this window. Maybe that is a high jitter. Maybe it was subliminal. Anyway, the point I'm trying to make it is the multi-peak algorithms does make testing a lot faster in the stimulation mode. So that was a quick overview of neuromuscular junction testing. We got about 10 minutes left, so let me go into other areas where we have made significant changes. So there is something called QRS Triggered SEP. And here is the problem. The ECG signal appears with large amplitude in recordings when our electrodes are at the Earth's point or in the cervical on the C7. And when this artifact overlaps the signal, that sweep must be removed. So that increases the time of examination. So here is a very clever way of excluding the ECG artifact. So what I'm going to do is go to the EP lab folder, and here is the QRS Triggered SEP. So the first thing that we are going to do is place some ECG electrodes. You can place electrodes anywhere on the body that are 2 places that are well separated from each other, and that will actually give you a good ECG signal. So here is channel 1, which is called the QRS monitor. you can see the QRS complex. You can adjust the trigger level to make a proper identification. The idea is that once we get a QRS complex, we are going to wait for 100 milliseconds. Let that artifact disappear. Then we are going to stimulate at 5 Hertz and deliver 3 stimulations. See, the time interval in 5 Hertz stimulation is 200 milliseconds. So 200 milliseconds and 200 milliseconds, that will be total of 3 stimulations. So the first stimulus, wait for 200 milliseconds. Second stimulus, wait for 200 milliseconds. Third stimulus. So that requires 400 milliseconds. And our time on the sweep is 50 milliseconds. This is 5 milliseconds per division. So the total is 550 milliseconds. That is shown as required interval. So what we are going to do is stimulate in between successive QRS complexes. And that's the way we are going to avoid the artifacts. Here is a calculation. This is the required interval. And we are also monitoring the subject's heart rate. So the R to R interval here is much higher than the required interval. So that is shown in green. Maybe the patient has a higher heart rate, in which case this time will be low. So we will need to make changes. So let me just illustrate it. If I were to set this for 4, notice that this is just pair line. Okay, it is telling that this is not adequate. I may have to reduce this, or I may have to make this into 6 Hertz or so. And now the time is 483, and that is much. So this is a simple way of doing the study. It will reduce the number of artifacts, and it will actually give you the responses much quicker because you are not rejecting any artifacts. An important part over here is artifact reject setup. It should be done independently for each channel because you don't want to have artifacts over in ECG. We are actually using that as an artifact. We want to detect it. We don't want to reject it. And you can set up independent limits over here. In the interest of the time, what I'm going to do is show you how the traces update. So you get an idea of what is happening. So you will see the EKG and the trace will be updated very rapidly. So here we go. No electrodes are placed. These are just open amplifiers. And ta-ta-ta, ta-ta-ta, ta-ta-ta. You can see how the traces update as a burst over here. Anyway, so that's the principle. I'm going to stop over here. It's a very interesting way of doing SEPs, especially if you're in a hostile environment or if you have got ECG artifacts and so forth. Let me show you a recording over here. So this was only after 140 sweeps. We already have very well identifiable potentials, and there are hardly any rejects in this recording. Now that we are talking about ECG, let's go to the autonomic function testing. We have redone the autonomic testing. You can see there are programs over here that are dedicated to different maneuvers. So you can do the Valsalva maneuver, you can do deep breathing and so forth. Let me get my electrodes set up over here. Okay, so we go into the R to R interval analysis. Right away, you will notice that we are detecting the QRS complex automatically. Previously, we used to use an amplitude, trigger, and delay line. Also note how the traces are rastering left, very much like an ECG recorder. You have a window that can be placed on a separate monitor. It tells you breathe normally, or it can guide you with breathing over here, breathe in, breathe out. So let's go ahead and record some signals over here. In the result table, you will notice that measurements are updated automatically. I deliberately tried to create an artifact over here by touching one of the electrodes. I want to come back and look at it. My electrodes are coming off. Let me erase this and start. Okay, and I will recreate the artifact. Here you can see the green highlight indicating that reference values are now supported in this test. These reference values are based on a summary article in Clinical Neurophysiology. It is readily available. Keep in mind that the reference values are based upon age. So you have to input the patient's date of birth before you use this program. I'm going to create an artifact. I'm going to touch the amplifier, my electrode. Okay, so there we had a few artifacts. Notice it has affected our R2R interval. And taking those intervals out used to be quite tedious in the old software. Things are much more simple now. Here I am using automatic scaling. Let me go into the manual scale over here, or auto scale rather over here. Just as we saw in single fiber jitter analysis, we have introduced these levels. So this can be used to get rid of any ectopic beats. You can raise it high, you can bring it up like this. And notice these two beats have been taken out. So that has been simplified significantly. Perhaps a better way is review the traces. So here is a yellow bar. You can bring it over here. You can see there are some incorrect intervals. This is the one I want to get rid of. Simply bring the mouse, click on it, get rid of it. Notice that it has fixed the issue. Perhaps one of the heartbeats was missed. I'm going to take this interval out. You see the large spike. You can either reduce the limit like this, or perhaps a better way is to identify the location, bring the cursor at the desired site or desired place, click with the left mouse, and the problem is fixed. So this simplifies our analysis in autonomic testing. And the same interface is used if you are trying to do the 30-15 test, or if you are trying to do Valsalva ratio, and so on and so forth. So going back to our theme, make it simple. We saw that in repetitive nerve stimulation. Things were simple, automated, and yet you have the full control on analysis. Single fiber EMG, a lot of automation, but you have full control, like deleting peaks, adding peaks, editing interpotential intervals, and so on and so forth. Same goes with QRS Triggered SEP. Try to minimize the artifacts. In R2R interval analysis, being able to correct ectopic beats or missed beats by the analysis. And that's what's going to make our software robust, and it's going to make it easier for testing. So I have shown you some of the new things. There is still a lot more that's available in the software. But to summarize, the Elite 2 software now provides you tools for better recording signals. You saw the QRS Triggered SEP, or the automated trigger in single fiber EMG. You got more measurements like JSON in single fiber EMG. We talked about residual latency and terminal latency index in nerve conduction in the previous talk. We talked about reference values. We have them now available for R2R interval analysis, and we also have them available in various forms for nerve conduction, including side-to-side difference. Reference images, along with a subscription for the streaming videos that you get, and this goes to the AANEM collaborative project. NCS Insight assessments via all kinds of comparison, motor to motor, motor to sensory, to a previous visit, That helps you identify the underlying pathology, and that helps you with review of signals. And of course, a lot of enhancements to the report. So we have enhanced the routine EMG, we have enhanced uncommon investigations, and enhanced the research studies. That, in a nutshell, is our path of our software development, currently resting at Elite 2, looking forward to future. So, George, I'm done with the talk. Do we have any questions?
Oh, thank you, Sanjeev. Very informative product tour number 2. I think we have, do you have normal values for the autonomic tests?
Yes, and they come from a publication from Clinical Neurophysiology. Those are IFCN guidelines. That article can be found readily on the internet.
How do we access part 1 of this webinar? Okay, I can answer that. All of our webinars are recorded on our Neurotraining Academy. So if you go to our Neurotraining Academy and under the section of recorded webinars, under the category of EMG, nerve conduction, EP, and neuromuscular ultrasound, you will find the part 1. And also part 2 will be there shortly after it is edited. So probably by next week, part 2 will be there. But if you have any difficulties in accessing either part 1 or part 2, just don't hesitate to reach out to me at neuro-training.academy@natus.com, and I'll be glad to help you along. This is kind of general. Is there somewhere text can go for this training? That would probably show text. I'm assuming it's text from an institution that are currently using the Elite software. My best bet would be to contact your local representative or send me the information with your location and some more specific information, and I can help guide this along. Okay, this one's for you, Sanjeev. What is the use of rise time in EMG?
The rise time, essentially, the rise time has no clinical significance. A short rise time only tells you that you are close to the generators of the motor unit. So it just ensures you that you are in the muscles that you are testing. Usually we like to get a sharp rising time. That has been the convention, but sometimes in patients with neuropathy, motor neuron disease, you may not get a short rise time. They have reinnervated motor units, they will have a high rise time. So that is just a kind of a quality assurance, if you want to call it, that I'm inside the muscle that I'm trying to test and I'm close to the motor units. It doesn't give us any information about pathology or anything.
The email is neuro-training.academy@natus.com. So that's how you can get in through to the Academy, and I will gladly be able to help you out or answer any questions you may have. There's another question. Do you have a link to the article with normal values for RR test?
I don't have it right now.
Okay. Again, if you would write to us to remind us what you're looking for with your email address, we will gladly provide that for you. How does the EMG Natus system actually calculate the firing rate? Is there something to do with feedback system of the muscular system?
Okay, there is no system that calculates the firing rate properly or correctly at all times. On the Natus system, there is something called firing rate that represents a kind of cumulative firing rate. So if it is let's say 25, and you see by visual assessment there are like 3 or 4 motor units, you know that's going to be your normal recruitment. Or if you see the cumulative firing rate of about 27, 28, but you see only 2 motor units, that's going to be reduced recruitment. So actually get the correct firing rate, you will need to identify the individual motor unit potentials and then look at the inter-discharge intervals. That is something that is done in our multi-MUP analysis program. So that's the quantitative EMG program. Perhaps I just show it to you very quickly how it happens. I will go into the multi-MUP. And choose an example signal over here. So this is the automated analysis where you can see the signal has been decomposed into individual motor unit potential waveforms. You can see the discharge pattern over here. Each vertical tick mark represents one firing. And in the bottom right over here, you can see how the firing rate is varying during the recording. So, and again, this is an average firing rate estimation. Firing rate changes instantaneously also. But if you really want a single motor unit firing rate, this is the kind of technique you want to use.
Okay, thank you. This last question, with respect to time, when will this version of software be released?
Elite 2 is released.
Yes, that's right. So it is released, so you can certainly take advantage of all the new features. And I think that's all for the questions we have. Again, send an email to neuro-training.academy@natus.com with any questions or links or information or training as was asked earlier. So on behalf of Natus and our Neurotraining Academy, it's been a pleasure having you join us. And again, I would like to thank our speaker, Dr. Sanjeev Nandedkar, and this will conclude our session. Thanks everyone for your participation. Enjoy the rest of your day or evening, and we will certainly look forward to seeing you next time.